Welcome to our video on preterm labor, Tocolytics, abnormal labor patterns, and breech presentation. Let's get started. Here's our overview slide of the topics we'll be discussing. Let's begin with preterm labor. Preterm labor is delivery between 24 and 37 weeks of gestation. The management of preterm labor depends on how premature the fetus is. Specifically, if the preterm labor occurs between 34 and 36 weeks of gestation, betamethasone administration for fetal lung maturation should be based on the clinician's judgment. However, penicillin for group B streptococcus prophylaxis should be given if the woman has a positive rectovaginal swab or her status is unknown. If, on the other hand, preterm delivery occurs from 32 to 34 weeks of gestation, betamethasone and penicillin should always be administered. Nifedipine can also be given as a tocolytic to delay delivery and allow fetal lung maturation. Finally, if the preterm labor starts from 24 to 32 weeks of gestation, then we should give betamethasone, penicillin, indomethacin, and magnesium sulfate to the mother. Indomethacin is a tocolytic just like nifedipine, while magnesium sulfate has neuroprotective properties by decreasing the risk of cerebral palsy in preterm neonates. All right, let's try a question. A 25-year-old G1P0 woman is brought to the emergency department at 30 weeks of gestation due to severe lower abdominal pain. She is feeling regular, progressively stronger uterine contractions every 2 minutes. Her vital signs are unremarkable. The physical exam shows cervical dilation at 4 centimeters and 30% effacement. What is the best treatment option for this patient? All right, this patient presents at 30 weeks of gestation due to severe lower abdominal pain and regular, progressively strong uterine contractions every 2 minutes. The cervix is 4 centimeters dilated and 30% effaced. All of these findings indicate preterm labor. In case of preterm labor from 24 to 32 weeks of gestation, we administered betamethasone to accelerate fetal lung maturity, penicillin for group B strep prophylaxis, indomethacin to delay labor, and magnesium sulfate for neuroprotection. Okay, now let's discuss tocolytics. Indomethacin is a cyclooxygenase inhibitor. It decreases the levels of prostaglandins that normally stimulate uterine contractions. Indomethacin is a first-line tocolytic from 24 to 32 weeks of gestation. However, it's rarely used beyond 32 weeks due to high risk of closing the ductus arteriosus. Additionally, indomethacin use is not recommended for more than 72 hours, again, due to the risk of closing the ductus arteriosus. Now let's talk about nifedipine. Nifedipine is a dihydropyridine calcium channel blocker. It's used between 32 weeks of gestation or when indomethacin is contraindicated. The side effects are due to vasodilation, resulting in hypotension and flushing. Terbutaline and ridodurine are beta-2 receptor agonists and are some of the other tocolytic agents that are used. However, they're rarely used. Okay, now we'll discuss abnormal labor patterns. The protracted latent phase is when the latent phase lasts greater than 20 hours in nulliparous patients or greater than 14 hours in multiparous women. Management of the protracted latent phase includes either discharge or inpatient monitoring based on the clinician's judgment. The protracted active phase, on the other hand, is when cervical dilation progresses by less than 1 centimeter per hour. Management includes oxytocin administration to increase the uterine pressure on the cervix and facilitate its dilation. Active phase arrest is characterized by no cervical change for greater than or equal to 4 hours with adequate contractions, or no cervical change for greater than or equal to 6 hours with inadequate contractions. Adequacy of uterine contractions is determined by the Montevideo unit, or MVU. An MVU greater than 200 indicates adequate contractions, while an MVU less than 200 indicates inadequate contractions. Management of active phase arrest is cesarean delivery because vaginal delivery will likely not progress any further. Here's an image from our partnership with Amboss, which will help us highlight several important features of the MVU. Let's illustrate how we can calculate this. Each uterine contraction is characterized by a peak pressure and a baseline pressure. We need to subtract the baseline pressure from the peak pressure for each contraction over 10 minutes, and then add up those values. For example, if there are 2 uterine contractions in 10 minutes, the peak pressure is 40 millimeters of mercury, the baseline pressure is 10 millimeters of mercury, and the pressure difference is 30 millimeters of mercury. So the MVU will be 60. Okay, now let's discuss breech presentation. This is when the presenting part is the fetal rump. There are several types of breech presentation, including frank, incomplete, complete, single footling, and double footling breech. We'll discuss these types on the next slide with an illustration. Before that, it's worth noting that the management of the fetus in breech presentation is either external cephalic version, followed by vaginal delivery, or cesarean delivery. External cephalic version is not always possible due to contraindications like placenta previa, vasa previa, intrauterine growth restriction, and preeclampsia. Also, vaginal delivery is usually avoided in persistent breech presentation due to a high risk of perinatal asphyxia and fetal death. Here we can see an image illustrating the different types of breech presentations. Again, we have frank, incomplete, complete, single footling, and double footling. Frank breech is characterized by flexed hips and extended knees. In contrast, the fetus in an incomplete breech presentation has flexed hips, one extended knee, and one flexed knee. Complete breech is characterized by bilaterally flexed hips and knees. Single footling breech means that one foot of the fetus is out of the cervix, while double footling breech means that both fetal feet are out of the cervix. Okay, let's wrap up with a question. A 31-year-old G3P2 woman at 38 weeks of gestation comes to the physician for a routine prenatal visit. All of her pregnancies were uncomplicated. The physical exam shows fundal height at 38 centimeters. A transabdominal ultrasound reveals that the fetal rump is closest to the maternal symphysis pubis and both hips and knees are flexed. What is the best mode of delivery for this patient? All right, this patient presents at 38 weeks of gestation. Her transabdominal ultrasound reveals that the fetal rump is closest to the maternal symphysis pubis, or in other words, the fetal rump is the presenting part. Additionally, both hips and knees are flexed, and this is a classic description of a complete breech presentation. Since this patient is already term, the baby will likely not change to cephalic presentation. Therefore, the best mode of delivery is cesarean section. And that concludes this section.